This editorially independent episode of New Retina Radio is supported by Alimera, a global pharmaceutical company whose mission is to be invaluable to patients, physicians, and partners concerned with retinal health and maintaining better vision longer. Alimera. We see more together.
Welcome to New Approaches to Chronic Postoperative Inflammation, a new Retina Radio miniseries. My name is John Kitchens, and I practice Retina at Retina Associates of Kentucky. On this miniseries, we'll examine the management strategies for one of the most confounding and frustrating complications we encounter as retina specialists. I'm talking about postoperative inflammation. If you missed our first episode with Dr. Lisa Faya and Daniel Kernan, please go back in your podcast feed and check it out. On this episode, we're going to talk about postoperative CME as it comes from our anterior segment colleagues to us, the retina specialists, and we'll talk about steroids and how we utilize steroids. I'm joined by two guests for this conversation, Vaidehi Dedania from NYU Langone Health in New York City. Hello, Vaidehi.
Hi, thank you for having me.
Thanks for joining us. And my good friend, David Eichenbaum from Retina and Vitreous Associates in Tampa, Florida. Hey, Dave.
Hey there. Happy to be here. Nice to see you and Vaidehi.
Well, listen, I'll tell you, Dave, I'll start with you here. You know, we all receive patients from our anterior segment colleagues, from optometrists that have recalcitrant or troublesome postoperative CME. Dave, first of all, any pearls for our anterior segment folks or optometrists as they're managing these patients that might cut down on the referrals to your practice?
This is a common condition, relatively speaking, just because there's so many cataract surgeries a year. I think the statistic is something like 4 million cataract surgeries a year in the US. 2% of them will have visually significant CME, so that's 80,000 cases a year. That's a lot of cases. And my advice to our colleagues who manage cataract surgery post-ops is make sure patients use their drops. If you see a patient with CME and you tell them use these drops, really give the drops a good try, because there's excellent literature describing how most of the post-operative CME will respond to topical treatment. Make sure to hammer them with the drops before sending them to us, because we'll usually start by telling them to hammer the drops or want a good history of them being compliant with the drops.
And Dave, are there any drops in particular? You know, we've got prednisolone acetate, we got difluprednate, we got nonsteroidals. Use them all? Is there a difference between steroids? What do you recommend?
I really like drops that patients will take, and that usually means two things. Number one, reasonable out of pocket. So prednisolone acetate is usually comparable with difluprednate these days. And number two, don't hurt to put in. And that's why I really like the more costly nonsteroidals like Prolensa, for example, as opposed to ketorolac or something like that. Because the ketorolac sting, I don't think they're going to get a corneal melt in the handful of weeks they're going to be on the drops. But if they don't use the nonsteroidals because they sting, they're not going to get a benefit from them. So a steroid they can afford that has some degree of potency, and a nonsteroidal that doesn't sting and has a coupon. Most of these drops come with coupons periodically. Make sure you have the coupon so they can afford it and they'll use it. I'm generally not too picky other than that. I don't think there's a magical drop that works for more patients in a quantifiable fashion.
Now, Vaidehi, let's say patients have done exactly what Dave, or doctors have done exactly what Dave's recommended, and the patient still ends up in your chair and they've had visually significant cystoid macular edema. How do you evaluate that patient? And then what are your first steps as far as managing those folks?
Yeah, so first I ask myself and I ask the patient, is this their first eye post-surgery, or is it their second eye, and did they have this in the other eye? If it's their second eye, but they didn't have any postoperative CME or inflammation in their first eye, that might take me down the route of less likely to work it up and start off with just treatment, which would be a longer steroid taper. If this is their second eye that they've had it in, I'd actually probably get a fluorescein, and based off of the imaging, consider an additional workup, because sometimes these patients have the potential to and are more prone and at risk for developing CME and postoperative inflammation, because they may have an underlying condition that had not previously either been identified or caused a problem, and post-surgery it is. So those are really my first steps when they come in. And I really think about how long that steroid taper was. If it was just about a month, then I definitely go for a longer taper. And if they've tapered over 3 months and it's still there, I think about another agent.
And so when you're thinking about that other agent, what's your first go-to thing that you're going to consider in those patients?
So after having done like topical steroids, if they have a lens in the bag, my first go-to agent tends to be Ozurdex. It has a short-lasting effect, but a lot of times one injection is all they need to really bring down that level of inflammation. Then they may not need anything again. And it gives me an idea of how they'll respond to intravitreal steroids. So that tends to be where I would go after topical.
And it's interesting that you mentioned if they have a lens in the bag. Talk about that a little bit. Why is that so important when you're considering using an Ozurdex?
Yeah, so if Ozurdex comes into the anterior chamber, it can be fairly disruptive and toxic to the cornea and the corneal endothelium. And often it requires you to have to go in and remove it if you can't have the patient position it back. And so in those circumstances, let's say they have an acrio, so they have a violation of the capsule, and so they have a communication between the anterior chamber and the posterior chamber. Those are patients I really do consider YUTIQ, because the implant, I've seen it sit in the AC without causing too much of a corneal disruption. Or I would consider a suprachoroidal steroid such as Xipere, because it works fairly well and you're not concerned that the implant's going to come into the AC.
Dave Vaidehi has mentioned a couple of different routes with the Ozurdex, the YUTIQ, which I really like in these patients, and then the Xipere. Are there any other options for these patients that have that compromised posterior capsule?
Yeah, so a couple of things. I really like what Vaidehi said, that the drops, you got to go kind of real slow on a taper if you get someone controlled. You can't just be like, oh, you're better, let's taper you down a drop every few days or a drop a week and get you off these drops in 3 or 4 weeks. You got to go low and slow, I tell them. And the patients come in really confused and distraught because all their other 98% of friends who had cataract surgery don't have pseudophakic CME. So they're all just trying. I tell them there's an orderly fashion for this, and we can figure out why they're more inflamed and why after cataract surgery we have to go through these processes. So I do the drops, or I make sure the drops have been done by the referring doctor. I still like to do subtenon's triamcinolone because it's painless for patients. It's extremely low cost. I usually give them one of those. I won't keep at that if they have a response, but it's incomplete or it's short acting, because otherwise they get ptosis and then they need all these shots. And I usually give them one, and I usually move on from that if it comes back or it's incomplete to the Ozurdex, the intravitreal dexamethasone implant. But it's important when you start to consider the intravitreals that you really look for signs of posterior non-infectious uveitis. What are those signs? What do I look for? What do I document as the CME comes back? And this is coming back usually a second or third or fourth time between the referring doctor, tapering the drops, doing the subtenons. It's coming back, it's coming back, it's coming back. If it's coming back this much, you're going to find some cells in the anterior chamber or in the vitreous or on the OCT. And to me, that's enough if you think about what the Sun criteria are for posterior non-infectious uveitis. Once you have cells, you're talking uveitis with secondary CME rather than CME without uveitis. So then you've made the diagnosis of chronic inflammation, posterior non-infectious uveitis. Then you meet the indication to help the patient with intravitreal dexamethasone implant. I agree with Vaidehi. The lens has to be at least in the sulcus or the bag for me. It can't be aphakic, it can't be ACIOL, it can't be a massively rented bag with a lens that's like canted out of the way. And then you can start using your intravitreal agents. And I like the same order. I don't pound them again and again and again with Ozurdexes. I like to do 2 or 3, and then I'll move on to the YUTIQ if the inflammation and the secondary CME keeps coming back. But I call it UME then. I've stopped calling it CME at some point on the diagnostic continuum here, and I call it uveitic macular edema.
And that's such a great point, Dave, that basically these patients really have to have a cause for that CME. CME is a finding, but the underlying cause really is inflammation and uveitis, and that helps give us that opening to be able to administer these other agents. Vaidehi, you mentioned that the YUTIQ or the fluocinolone acetonide implant can be tolerated in the anterior segment. I too have seen it in the anterior segment. It's been tolerated in the anterior segment. How does that differ from a dexamethasone implant as far as urgency to get it out and effectiveness and whatnot?
Yeah, so I've actually, I would say for a dexamethasone implant, I try to take them if I can't. What I will first try is dilating them, have them lay backwards. And I've had one patient that's very successful with. This doesn't happen very often. In the patients that's not successful with, I try to take them to the OR within 24 hours to remove that implant from the anterior chamber. And that patient is, of course, not going to have another Ozurdex with me. I'm going to choose another agent for them. For the YUTIQ, I actually just leave it. I have a patient with a slight adhesion to the iris right now, and she's seeing 20/20. She's doing beautifully. If I go in and remove that implant or move it to the posterior chamber, I'm likely to disrupt that. And her cornea looks great. It's not causing any concern. So I've left that in place for months.
Yeah, and I agree with you. Listen, I've had a patient that's had a dexamethasone Ozurdex implant in the anterior chamber, and it really can wreak havoc on the cornea. Listen, we're getting some great pearls from Vaidehi and David here. We're going to take a break, and after we come back from the break, we're going to talk more specifically about different steroid therapeutics for our patients with macular edema and get insights from David and Vaidehi about each one. So come back and join us after this break.
This editorially independent episode of New Retina Radio is supported by Alimera, a global pharmaceutical company whose mission is to be invaluable to patients, physicians, and partners concerned with retinal health and maintaining better vision longer. Alimera. We see more together.
Welcome back to New Approaches to Chronic Postoperative Inflammation, a New Retina Radio miniseries. I want to examine a different route here. We're going to do a little bit of rapid fire, Vaidehi and David, about the steroids that we use inside the eye, the routes we use them, the different steroids and whatnot. I'm going to give each of you a steroid and a route of administration, and you kind of give me the pros and cons and when you might use it. Vaidehi, I'm going to be tough on you here to start out. Intravitreal triamcinolone, and specifically intravitreal triesence. How do you like it? When do you use it? How do you use it?
I will say I have not used it in about 6 years with some of the other agents out there, but it works very well. Part of the reason I haven't used it is the ease of access to other medications such as Ozurdex and the similar effect and the more expected and timeliness of the medication. I have had a few patients come back post-injection from elsewhere, and they have triescence in their AC, and they're disrupted by the snow everywhere, which you don't tend to see with the other medications. That said, previously it's been quite accessible. It's cost effective, and it's quite easy to administer. But with lately also with more back ordered issues, I really do prefer some of the other intravitreal corticosteroids.
Yeah, sadly, I'm afraid that we haven't had access to it for a couple of years, and it's kind of bounced around between different companies and manufacturers, and I'm not sure when or if it's ever going to come off back order. I've heard some rumors about availability and whatnot. David, jumping to you now, intravitreal dexamethasone implants or the Ozurdex implants. When do you use it? How do you use it? What do you expect from it?
Intravitreal Ozurdex, I would argue the go-to intravitreal steroid in 2023 as a first shot at putting something inside the eye. It's got a lot of indications, which is cool. Everyone's got a lot of experience with it now, which is cool. It's readily available. It's broadly covered on commercial and Medicare Advantage plans. I use it when I'm going inside the eye. I trained in Boston at Tufts, where intravitreal triamcinolone was birthed by Martinez way back in, I think, 2003 or 4 or something like that. So I swam in intravitreal triamcinolone for a long time, and Triessence, but I've fully migrated away from it even before there were issues with getting it, with ordering it. Just like Vaidehi said, you have less predictable pressure problems with Ozurdex. You don't have the snow with Ozurdex. You don't have the paradoxical inflammation that earned Kenalog 40 a black box with Ozurdex. You have all these advantages to it. So I use it a lot as my go-to intravitreal steroid. And I find that's easy to use it on label, easy to get, and it always goes away completely. The downside with it is patients see it. They see this thing floating around, especially if they're vitrectomized. But I tell them an Ozurdex is like a baby. Neither one stays in there forever, and the Ozurdex will dissolve to be something that's completely gone. And patients love that analogy. But if they don't tolerate that bouncy Ozurdex, think a little bit about the other steroids. That being said, the Utiques and the Iluvians, they don't really bounce around like the Ozurdex. They kind of get stuck in the vitreous base, even in a vitrectomized patient. So I have gone from a intolerant Ozurdex patient to a tolerant Utique or Iluvian patient a number of times, and I've almost never been burned on that, which is a really interesting and important insight if you're going to be playing with the non-erodible long-term intravitreal corticosteroids.
Well, you lead us perfectly into that. Vaidehi, David mentioned the Utique, or the extended release fluocinolone implant for uveitis. When do you use this? What do you expect from it? How do you use it?
I use it for post-operative CME or uveitis. I will probably give the patient a shot at 2 Ozurdexes, and if they respond well but they have a recurrence, that's when I then move to the Utique. Generally, these patients are older, and so they're not going to require a number of these injections. But even when they have the implant there, just like David mentioned, they don't always notice it. So the fact that the implant portions of it are not degradable, it's fine. It's not too concerning to me. If they're younger, and I do think twice about it if they're much younger, because a lot of times these patients need long-term control. And so if they had surgery at a younger age and they do have this inflammation, but they have other reasons to have this inflammation, such as a systemic condition, those are the patients that I would actually potentially do a Utique on, but also start some immunomodulatory therapy on, so that I can avoid having to do these injections every year for them and buy them some time.
David, Utique and Illuvian are very, very similar. In fact, some would say the same basic thing as far as that goes. What have we learned from years and years of access to Illuvian that we can, I guess, learn from or utilize when we're planning to use Utique in our patients?
So I think the most important learning that I translate from lots and lots of Iluvian experience to now a accumulating Utique experience is when to inject the drug, because this is a trickle. I remember the old Iluvian commercial kind of program where it looked like a drippy shower, like the shower in my dorm room that would never stop dripping. That was so annoying, but so apropos to describe the zero order kinetics and the way that the Iluvian and the Utique work. So it's never a bolus. So what I learned from Iluvian, I've translated very successfully to Utique, is start the drip when you don't need a lot of drug. You get the eye quiet, you get the eye controlled. When I made the decision to do a Utique in a patient who has posterior non-infectious uveitis, often after surgery with cystoid uveitic macular edema, I'll put it in an Ozurdex, and within 2 to 4 weeks, I'll put in the Utique, because the Ozurdex has this big bolus. If you look at and study the pharmacokinetics of the Ozurdex, a lot of dexamethasone comes out at first as it begins to get eroded and looks like Swiss cheese after about a month, and there's tons of exposure. Your eye is quiet, everything is happy, the cytokines are being suppressed. Then you pop in the Utique or the Iluvian if it's diabetic who's inflammatory. But in this case, we're talking about the patient who's purely inflammatory. So you pop in the Utique, and then you begin to ride the wave of corticosteroid suppression for hopefully a very long time, hopefully at least 18 to 24 months, up to 36 months, which is a good long time for these frustrated patients.
Dave, that's such a salient point. I think that's critical is that it isn't that big bolus that gets the, very edematous macula dried out. It's what keeps it there once it's already dried out. So I think that's a great point. Vaidehi, I don't know how much experience you have with this suprachoroidal triamcinolone known as Xipere, but what are your thoughts on that?
It has not been my go-to first-line agent, but I have found it quite efficacious in patients who are aphakic or have an acreose or a lens that's been scleral fixated, and it works very well. I found in the patients that I've used it on that it has a similar time frame of effect to an Ozurdex, which is about 3 months. Sometimes it'll get you out to 6 months. It's fairly easy to administer once you've done it a few times. And so I've actually had great luck with it, and I think it works quite well.
And Dave, what's your thoughts on Xipere?
So I think the coolest thing about Xipere, and it is cool, is that we're getting into the suprachoroidal space, and it is the perfect drug to kind of gain experience individually and as a field with the suprachoroidal space. We know a boatload about Kenalog. If you wind up going intravitreal, it's intravitreal Kenalog. We've done that for a generation now. We are learning how to use the injector, who's tolerant of it, what the techniques are, what the drug kind of looks like when it is in the suprachoroidal space. When you expand that potential space, it is the intro to what I think will be a variety of therapeutics in the suprachoroidal space, possibly also administered with the Clearside injector, possibly administered with other injectors or other various surgical devices. But I think the coolest thing about it is we are really looking at it as the opening chapter in utilizing the potential space of the suprachoroidal compartment.
It amazes me that there can be such access and IP around a short needle. Basically that's what it is. It's just a 1 millimeter needle that allows us access, and I'm simplifying it obviously, but allows us the ability to inject novelly into that suprachoroidal space. And I agree, it is a great starting point for a variety of different therapeutics. Listen, you guys have been absolutely great. You've been entertaining, you've been educational. Vaidehi, David, I want to thank you for joining me on this new Retina Radio mini-series, New Approaches to Chronic Postoperative Inflammation. We have one more episode coming out, so stay subscribed to New Retina Radio so that these episodes automatically appear in your podcast feed. Remember to go back and listen to our previous episode and catch that with Lisa Faya and Dan Kiernan. For now, my name is John Kitchens. Thanks for joining us.